Good morning. Welcome to another edition of McMaster Perspective. We have a special guest today, distinguished professor of cardiology and medicine at McMaster University, Professor Salim Yusuf. He has a lot of different titles, including past president of the World Heart Federation and founding and executive director of Population Health Research Institute, a major research organizations from which a lot of major studies about which we all hear is coming. Professor Yusuf, welcome and thank you for agreeing to provide us with your time. The reason that I asked for this interview was the paper which I looked at, and it dealt with effects of what is labeled as polypill on cognitive and functional situation of elderly people. It sounds a little enigmatic to people who don't know what it is about. Would you mind to introduce to us both the concept of polypill and then your own achievements in this area?
Well, we now know several things. First, that statins that lower LDL lowers cardiovascular disease. We also know that blood pressure lowering, especially combination drugs, will also lower blood pressure to a great extent and will reduce cardiovascular disease. And in high-risk people, aspirin also benefits people. So the concept is very simple. First, if we combine these drugs, we should get a bigger effect on risk factors, and that should translate into a bigger effect on clinical events. The second is, given that these things are safe, the additive use doesn't increase side effects. But something that is even bigger is that in most evaluations of drugs for prevention, people have chosen high-risk people or people with cardiovascular disease. The problem with that is only 20%, 10 to 20% of cardiovascular disease events in a community come from the high-risk people. So if we focus only on the high-risk people, that is secondary prevention, we will lose the opportunity of intervening in 80 to 90% of the source of events. Now, it will be more than 80 and 90% of the population, maybe 90 or 95%. So the two striking things is that by giving the polypill, especially with aspirin in primary prevention, we can reduce cardiovascular events by 50% within 5 years. That is huge. And given that cardiovascular disease is the commonest disease burden in the world, 23 million people suffer from, die from cardiovascular disease. 2 to 3 times that number have non-fatal events like a non-fatal heart attack or a stroke. We're talking of if everybody used it. Of course, not everybody will use it, but let us just say a quarter of the people used it, we will be preventing about 15 million premature cardiovascular disease deaths and cardiovascular events every year. Now, obviously, if everybody uses it or 90% uses it, the numbers will be higher. This will be as big a public health impact as complete cessation of tobacco worldwide. So that's not trivial. The second is the polypill is highly cost effective, in fact, cost savings, because if you prevent hospitalizations and revascularizations and heart failure, you save costs. So it's a highly cost-effective therapy, and by a simple strategy of taking people over a certain age, say 50 or 55, and maybe one simple risk factor that you know, that is self-reported hypertension, self-reported diabetes, age, as I told you, or self-reported cardiovascular disease, there is no intensive screening needed. And yet you pick up a large part of the people who will get future events. Screening becomes inexpensive, and it's easy for doctors And for that matter, doctors are not the primary people we should use in prevention. We should be using non-physician health workers. Several studies have shown that. So the polypill is a delivery mechanism to take 3 sets of interventions. It could be 2, it could be 3 sets. Putting it into a simple pill, giving it at moderate doses, not high doses, so that you don't risk side effects. And it's delivered by non-physicians. This makes prevention incredibly effective and incredibly cost-effective. So that's the concept of the polypill. And the trials now show that you can reduce cardiovascular disease by 50%, despite modest difference in LDL, only 0.6, not the 1 millimole or more that you get with intensive therapy. Blood pressure is only lowered by 6 millimeters, which is not as big as the 20 millimeters. If you go intensive blood pressure lowering in hypertensives, and yet you get a big effect, but very few side effects. So that's the big advance. The challenge is putting it into practice simply because of 2 things. First is the mindset of physicians is you got to take each drug and titrate individually and do it 1 patient at a time. When you have a condition that will puts the almost entire adult population is at risk, you cannot do treatments one by one. You have to take a mass approach. It's like saying we're going to do vaccination, but we're only going to do it in certain high-risk groups. That's not very cost-effective, not very sensible either. So the first is to change the mindset of physicians. And what this is that this involves is that the treatment paradigm becomes close to a population paradigm, And for some things you need an individualized paradigm. So for instance, you use the polypill as a general thing. And then if you still have people with elevated blood pressure or elevated lipids, you can individualize what else you do. So individualized medicine and a broad approach, a population-based approach are complementary. They're not contradictory.
Yeah, no, you're making a very compelling argument here. Thinking about it, I do not believe it would happen on individual physicians level, because you will have to convince thousands, if not hundreds of thousands in some countries. It would be on a public health interventions and organizational support for such programs. Do I steer correctly? Okay.
Yeah, that's right. So that's the second challenge, convincing physicians to use it. The third thing is, because all the components of the polypill are generic, there is little profit to be made by pharma companies, which means the big pharma are not interested in it, And this has been our biggest challenge. We've got some small companies to market it, but they're usually country by country. They may market it in one country or one region, but not globally. Some companies like Eli Lilly are considering developing a polypill for diabetes that would be marketed at low cost worldwide. So that's the second thing. The third thing is the thinking of organizations like the WHO, which thinks of you only have to use drugs in high-risk people. Now, that's perfectly fine if you have drugs that are expensive, drugs that are not safe. But when 80% of your events comes from the average risk group, that strategy means you're missing out on 80%. So there's a huge educational challenge at the WHO level and at the guidelines level, which we are working on. We've now submitted an application to the WHO to include the polypill in the essential medicines list for diabetes and hypertension primary prevention, in addition to secondary prevention. That's a starting point. Once that's approved and people start to use it, that's still hundreds of millions of people in the world who will benefit. Then people will start to gradually expand the indication. So our strategy in the next decade, it will take at least a decade, is to support various companies to develop polypills, and then to try to get the polypill into guidelines, with a change, because WHO strategy is you need a 10-year X% risk. It used to be 20% risk, that is 2% per year to prescribe drugs. Like for blood pressure, they are lowering that to 15 or 10%. Now that's getting closer to a population paradigm. Now, the paper that piqued your interest was the one on the polypill and cognitive function. As you know, cognitive dysfunction is epidemiologically related to elevated blood pressure and elevated lipids. However, not a single study has shown that reducing lipids and blood pressure clearly, with one or two exceptions, reduces dementia or cognitive dysfunction. The SPRINT study had a hint in one paper, but then later on it disappeared. So we thought the polypill would be a good intervention to test. We tested it, and most of the scales that we measured did not show any beneficial effect, but it didn't show any harmful effect either. But some of the scales, called the SAGE scale, which measured function, that is physical function, and physical function frailty is part of cognitive decline, seem to benefit. This requires confirmation. I wouldn't say this is the be it and the end all. And it may well be that dementia due to vascular disease may be a different process from heart attacks or strokes due to vascular disease. This might be more microvascular disease, and maybe our standard interventions are not the ones for it. I mean, we do know that dulaglutide, there is one trial with dulaglutide that Herzl-Gerstein published that showed an improvement in cognitive function in a large randomized trial. And dulaglutide, the incretin-based treatments, do have some added benefits, including weight loss. And we are seeing weight is a strong predictor of cognitive decline and MRI changes in the brain. So I think the polypill area is not necessarily the final answer to dementia, but it certainly has given us leads, which we are exploring. So the other thing is we have been working with the global burden of disease people, and their estimates is that the polypill in the net by 2050, at 50% use, will prevent 120 million premature deaths in the world at 50% use.
Well, I'm not sure whether we will observe this, but it's extremely compelling reasons. I looked at your original paper in the primary prevention in people who had some risk factors, as you mentioned, either age or hypertension or lipids or diabetes or whatnot. And it appears that the absolute difference in something like major events, even mortality over the period of few years was for mortality close to 1%, meaning that you would probably need to subject about 100 people to treatment to prevent a death.
Roman, this is where McMaster has distorted the world.
Okay, the world. Please straighten me out.
Yeah, this NNT concept is okay for high-risk people in treating people, but it is not the right yardstick to use for prevention. Like if you did that for vaccines, you'll never vaccinate anybody in the world with anything, okay? So it's actually quite a short-sighted thing. Now, you've got to think of NNTs in multiple concepts. 1% spread out around the whole world is huge.
Absolutely.
1% in terms of very high-risk populations is tiny. So I think you've got to say, what is the population at risk? Does 1% make a big difference? What is the cost of the treatment? What is the side effects of the treatment? Clearly, if the cost is high or the side effects are high, then we need a different yardstick. I think the NNT concept is a big disservice to public health. It works in the context of clinical medicine. And the honest answer is, if something that is expensive today, 20 years from now, will be inexpensive. For instance, statins were considered expensive when they first came out. Today, you know, they're like sweeties. So I think the fundamental thinking around NNT needs to be reoriented, and it needs to be targeted for different interventions, different types of populations, where the side effects and all of those occurs. This is one of the mindless things that have come out of McMaster. Sorry to put it that way. And
well, it's an interesting concept. The idea of, we are all, no, not all, you are a public health promoter in a big way, and your perception here is crucial. And you made a very compelling point, both for polypill and for public health perspective on its use. Professor Yusuf, I want to thank you very much for this part of an interview, and with your permission, we'll record something more. Thank you very much for your time.
Thank you. You know what, before you go off,
I'm not going anywhere.
No, before you end the recording, at least I'm not saying the NNT doesn't have a value in certain circumstances. With expensive therapies that have side effects in certain disease states, they do have a value.
I understand.
Yeah, so I think that's the distinction that I think if we all made, we will actually benefit health more than blanket use of an NNT number.
Yeah, I mean, NNT may mean completely different things if the burden of intervention is extremely long, extremely expensive, and carries side effects, as you are pointing out. If that is, even if it's long but inexpensive, without side effects, and with a low burden on the person, the look at it needs to be different. Thank you very much once again, and I hope to host you again soon. Thank you.
Thank you.